Okay, so we get started.
Okay, sir. We can start, sir.
Okay, today's lecture, as I mentioned earlier, is on viral hepatitis. Next slide, please. All right. Well, there are various kinds of viruses that cause hepatitis, which is inflammation of the liver. It's one of the commonest diseases of the world. In India, hepatitis B prevalence is 3.7%, which means 3.7% of the population has hepatitis at any given time. We have 4 crore hepatitis B virus patients and 1.2 crore hepatitis C patients. And among the tribals, the prevalence rate is even higher, is close to 12%. 1 in every 8 people in tribal area has got some kind of hepatitis. So it's a pretty debilitating disease. It is one of the commonest, if not the commonest, disease in the world and India. Next slide, please. Like I mentioned, there's hepatitis A, B, C, D, and E among the viral group. Besides that, herpes simplex virus called HSV and EBV, Epstein-Barr virus, can also cause hepatitis. Many other viruses can cause, including COVID virus, give you some liver enzyme elevation. But today we'll confine ourselves to hepatitis B and C. I will structure that I'll talk about B virus for about 15 minutes and then C virus for next 15 minutes. Then I'll take any questions, or if you want me to cut it shorter, I can do that also. This is the structure of hepatitis B. Now, this is important because this terminology that's given in blue around it, I'm going to talk about it throughout. Hepatitis B is a double-stranded DNA virus. You see the DNA right in the core of this diagram here. The outer layer is a bilipid layer, like many viruses have. And under that, there's the hepatitis surface antigen, HBsAg, right at the bottom left. This is the antigen we measure in blood. Then we have HBeG, hepatitis B antigen. And then we have hepatitis B core antigen. So the measurements are normally done on these, that is the DNA, surface antigen, core antigen, and E antigen. The gentleman on the up corner is Baruch Blumberg, who got the Nobel Prize for discovering this virus in 1976. He was working in tribal population in Australia, and so this was named initially as Australia antigen. You may have heard the disease caused by hepatitis B was called at that time serum hepatitis, as opposed to another condition called infectious hepatitis, which is hepatitis A. Nowadays, we just call it hepatitis B and don't call it serum hepatitis anymore. An Australia antigen is called hepatitis B virus, or HBV, as a short form. Next slide, please. This shows a diagram how the virus enters the liver cell. The big picture, the big rectangle is the liver cell. As you already know, viruses enter the cells by multiple processes. Here we've shown is a process called endocytosis. The hepatitis B virus right on the top in green with a red envelope forms a small vesicle there with the hepatic membrane, enters the cell on top left, and then this virus from that vacuole is extruded. The green hexagon that you see is the virus. It enters the nucleus, and then in nucleus, the DNA comes out, which is a double circular DNA. which comes out, and first thing that happens is the DNA forms a circular DNA there, which stays there forever and ever. This DNA is then transcribed, and the transcribed DNA moves out of the nucleus, where further replication of viruses happen, and this virus then acquires a capsid in the endoplasmic reticulum, and then is excreted out of the hepatocyte again, only to enter new cells. Now, mind you, while this has happened, as I mentioned earlier, the circular DNA stays in the nucleus of the liver cell or the hepatocyte, which means any treatment has to penetrate into the nucleus to kill the circular DNA, and we don't have a medicine like that at the moment. We can kill the virus in the hepatocyte or outside in the blood, but not in the DNA. So this at the moment is a permanent infection, and the DNA stays in the nucleus only to reactivate in future. Next slide, please. How does the disease progress? After you get infected, the infection is normally through body fluids. The transmission is almost identical to hepatitis. Is identical to HIV. It's body fluid, close contact with the infected person. The infection is transmitted through saliva and through sexual intimacy, and not through food and water generally, unlike hepatitis A, and also by IV injections, by drug abuse, or abusing syringes for injecting drugs. The incubation is up to 6 weeks, and acute phase lasts about 3 months. Then there's a convalescence phase. Most of the people do get better after 3 months of convalescence. In fact, majority people, 90% adults, get better. And then people, some unfortunate people, about 9% people will become chronic hepatitis patients. And there's 1% people who don't make it and they die during the acute illness. The adult, this is the story of the adults, but if you acquire hepatitis B at birth, then 80 to 90% of the people continue to have hepatitis for the rest of their lives. And children who acquire hepatitis in childhood, not at birth, about 50% go to chronic hepatitis. And of course, chronic hepatitis leads to cirrhosis of the liver and hepatocellular carcinoma, or the hepatoma. Next slide, please. So this is a graphic representation of acute hepatitis. You have an incubation period, if you see the top line, incubation period, then you have the acute disease, and then you have convalescence period. During incubation period and during active disease, you can measure hepatitis B surface antigen in the blood, and you can also test for hepatitis B core antigen in the blood. And in convalescence period, you acquire core antibody and then hepatitis B surface antibody. So this is the acute phase reaction. During acute phase, since the virus is actively multiplying, there's a high DNA level of DNA polymerase activity, which can be measured in the blood. Next slide, please. Let's move on to the next slide. I mentioned earlier, 90% of patients recover from acute hepatitis B. About 1% die, and 9%, remaining 9% become chronic hepatitis. If you remember the first slide, I had mentioned you about an E antigen. Then people with acute hepatitis and active hepatitis have an E antigen, which is positive. Besides surface antigen, E antigen is positive too. And gradually, many people in chronic hepatitis lose this E antigen. They become E antigen negative. Normally, the DNA is less than 2,000 level international units per ml, and about 20,000 is definitely a very active disease. So these are the measurable tests that we do in the blood routinely on hepatitis B patients. That's why I'm repeating these names and levels frequently. Next slide, please. This is another way to look at it. If you have hepatitis B, depending on the age, you have a perinatal that's at birth. Through the normal delivery, they acquire from the vaginal fluids, the infant acquires this hepatitis B, or you can acquire it in childhood, or you can acquire as an adult. Now, adults are the luckiest ones. They get infected and they recover, most of them resolve, 90%. Some become chronic hepatitis, and the square in the center shows immune active. It's another way of saying chronic hepatitis, which is active. So from inactive, they can go into immune active stage. Now, children always go through immune active stage before they become inactive, and so do the congenital hepatitis or perinatal hepatitis people. They become immune active. Now, immune active can be treated and can be resolved, but the reactivation can happen again. So you can see this, there's to and fro between activity and inactivity if you haven't recovered. And if you're unlucky, it's a lifelong process till the person dies of cirrhosis or hepatocellular carcinoma. Next slide, please. This is a little complicated, crowded slide, but I like you to concentrate on the second vertical column, which is adult on the top, chronic hepatitis B. Let's go through this. Rest I can explain. That this person goes through phases that I said earlier. It's an immune active phase or an inactive phase, and again, reactivation. So in an immune active phase, an active chronic hepatitis, his hepatitis B surface antigen will be positive in the blood. It'll be E antigen positive. He will have anti-HBE, that's HBE antibody, either will be negative or positive. Liver enzymes, ALT, will be elevated. HBV DNA, if you remember earlier slide I mentioned, will be more than 20,000 units. If you do a biopsy, you see inflammation, necrosis. Patient will have symptoms, which are jaundice, weight loss, poor appetite, fever, malaise, body aches, and these people do need treatment. If you go to the next vertical column next to it is inactive stage. Inactive stage people, though they have chronic hepatitis, but they're inactive, they don't need any treatment, and the blood parameters change. Next slide, please. So in chronic hepatitis, people who have chronic hepatitis, our idea is that we should prevent them from having cirrhosis and prevent hepatocellular carcinoma. So you have to have a surveillance method of checking them every few months, normally every 6 months, to see whether they're progressing. Now we have the age-old test that we did before, which said earlier I mentioned DNA level and ES and core antigen antibodies, but there are other fancy tests that we do on them, and they're mentioned here. The lowest most square is chronic hepatitis B. If you're just monitoring it, you can do these are the newer tests that we can do: MAC2 binding protein isomer, or you can do a hepatitis B core-related antigen and HBV DNA and surface antigen. During surveillance stage, the non-invasive tests, which are they're mainly ultrasound and radiographic tests, but you can also do a plate APRI score, which is a platelet ratio to the AST level. And that APRI score can tell you platelet outs goes down and AST level goes up, that signifies chronic disease. And you can see the fibroelasticity, that means the stiffness of the liver measured by ultrasound will tell you whether the liver is getting stiffer or not. Similarly, hepatocellular carcinoma screening is done through ultrasound, other imaging techniques, which will show you a nodule getting bigger and so on, which will come to carcinoma markers in the liver. You have multiple markers. The commonest one is the AFP, or the alpha fetoprotein. And second one that's used is PIVCA2, which is protein-induced vitamin K. These are blood tests. You can send for these blood tests. Any reasonable lab, they'll tell you whether they're positive or negative. Next slide, please. Obviously, you got to treat these people. As I mentioned right in the beginning, the hepatitis B circular DNA stays in the nucleus forever and ever. If the person is unlucky, he doesn't clear it. So we have only two kinds of treatments for this. One is called the functional cure, which is defined as complete absence of HBsG, the surface antigen, and the DNA is undetectable. And the second is a partial cure, which is more common, which is hepatitis B surface antigens disappeared and DNA is less than 2,000. As I mentioned earlier, these can reactivate itself where the DNA becomes more than 20,000 and hepatitis B surface can show up in the blood again. So the indications treatment are only if there's immune active phase or there's evidence of moderate inflammation on liver biopsy or the staging techniques that I mentioned earlier. But cirrhosis should be treated regardless of blood tests. If there's an indication of cirrhosis, they deserve treatment, and hepatitis B DNA more than 20,000 deserves treatment immediately, even if the other associated conditions or tests are not present. So cirrhosis by itself is an indication treatment. Hepatitis B DNA more than 20,000 is indication treatment. And then immune active disease is indication for treatment. Next slide, please. Next. No, before that, okay. And we have this hepatitis B therapy. Multiple drugs have been used over the years. The commonest one, which is we use nowadays, is tenofovir, fairly good, and that comes in two kind of formats, which is alphenamide and fumarate. There are some unusual side effects, lactic acidosis being the common, but one should be in guard for that. It's treatable, reversible. So this is the commonest drug we use. Along with this, entecavir is used, and these have less, the virus does not develop resistance to these drugs. Earlier drugs that were used were given at the bottom of the slide called lamivudine, but most of the people got resistant to this drug in very short time. So the current standard of care is tenofovir and entecavir. These are antiviral drugs. Next slide, please. Now we moved on to hepatitis C. I said earlier, Baruch Bloomberg got the Nobel Prize in discovering hepatitis B, or called Australian antigen, in 1976. His assistant at that time was a person called Harvey Atler, who's shown on this slide. Harvey Atler went on to become a Nobel laureate himself. He got the Nobel Prize in discovering hepatitis C and got the Nobel Prize last year with other two doctors, Michael Houghton and Charles Rice, for discovering hepatitis C and growing it and proving it is the cause of hepatitis C. Now, it so happened that after hepatitis B was discovered, all blood was from the blood banks was checked for hepatitis B before transfusion. And even hepatitis B negative blood given to many people still develop hepatitis. It was called non-A, non-B hepatitis. Because of these three gentlemen, these non-A, non-B hepatitis was found to be another virus called hepatitis C virus. They saw the virus and saw the structure and discovered the mode of transmission. Next, please. This is what hepatitis C looks like. Found out this is an RNA virus, a single strand RNA virus. Again, like any other virus, it has an envelope shown in pink here, and the RNA strand is shown right in the center of this big blob, and has proteins around it. Normally it has 10 proteins. This virus is a small one. It has 10 proteins, and 3 of them are structural proteins shown in orange color, and there are about 7 non-structural proteins. Now, this is important because our antiviral therapy is directed towards the non-structural proteins of this virus, shown in blue here. Next slide, please. RNA virus diagram is shown in blue here, is a single strand RNA virus. It is slightly larger than the hepatitis B. Hepatitis B virus about 40 nanometers. This one is 55 to 65 nanometers in diameter. And like I mentioned, it's 10 different proteins. Most of them are non-structural, and 3 of them structural. The chronically infected people generate 10 raised to power 12, that is 10 billion viral particles daily. To give you a sense of idea, we have 1.4 billion populated people in India. We're producing close to 9 to 10 times of that virus particles inside the liver cells, inside the body every day. You can imagine the viral load on a person with hepatitis C. And genetic variability happens, as you have noticed in the newspapers, how COVID virus is also mutating. So all viruses mutate. They mutate every day. When you have production of 10 billion virus particles every day, you can imagine the variability that happens with each replication. So, and possibility that's very high. So each person that is not infected really with one uniform virus, but is a quasi-species in each individual. He has multiple variations of the same virus, which happens during the replication process. So generally speaking, there's 6 genotypes recognized. They're named 1 to 6. They're numbered genotype 1 to 6. Next slide, please. Genotype 1 is commonest in South India. Next slide. Genotype 1 is commoner in South India, and genotype 3 is in North India. Together, between genotype 3 and 1, they form 90% of all the viruses known. And now this is an implication in therapy, because certain genotypes are prevalent in one place, and therefore they're amenable to different antiviral drugs. Like genotype 1 here is commoner in South India, genotype 3. So when you diagnose a person with hepatitis C, the second step should be, one should do the genotype to know which antiviral to give or what the prognosis is. These have been defined. Now, these 6 genotypes occur because of the fast replication, and these are the distinct genotypes. Next slide, please. So this virus again, and it does not enter the nucleus. It stays in the cytoplasm and makes these proteins there, which then replicate in the cytoplasm and then assemble again in the cytoplasm, and there's extruded from the hepatocyte, and that infects the other cells. This is the common thing with viruses. All viruses do the same. Similarly, similar to COVID, which enters the cell through, as you heard of, through ACE receptors on the respiratory mucosa and other, wherever there's ACE receptors, the virus can enter. We're talking the COVID virus here for a moment. So all viruses enter the cell, replicate inside the cell, come out of the cell, infect the other cells, and therefore cause a disease. And they replicate rapidly in millions every day, even in billions every day. Next slide, please. This is again a graphic diagram that hepatitis C, most of the people are asymptomatic. You don't even diagnose as symptomatic hepatitis C because it's a mild disease and nobody notices it and it just goes away. It's the asymptomatic people where 90% of them are asymptomatic, out of which 90% become chronic and 10% recover. The lucky symptomatic people, which only 10%, only 50% become chronic. So you rather have a symptomatic hepatitis C, your chances of becoming chronic are less. But with the milder asymptomatic form, your chronicity is 90%. And 30 to 50% people develop cirrhosis in 20 years. And then it progresses to hepatocellular carcinoma at the rate of 1 to 4% per year. So the commonest cause of hepatocellular carcinoma in the world at the moment is these viruses, hepatitis B and C. B mostly in the underdeveloped world, and hepatitis C causing the hepatocellular carcinoma in the developed world where there's less prevalence of hepatitis B. Most of the transplants nowadays in the Western world is done because of cirrhosis due to hepatitis C. Next slide, please. Now, this diagram shows where the certain drugs would affect the viral replication. There are two drugs that we use, or one drug that we use really commonly, sofosbuvir, which is a nucleoside analog, which means at a stage when virus is assembling in this pink and the blue area of the slide inside the cytoplasm, these analogs enter the cell and stop replication. They enter the viral genome and stop replication. A pretty effective drug. So sofosbuvir is a miracle drug because of hepatitis C, which we call non-A, non-B hepatitis, didn't know what to do with this, and people lived along and developed cirrhosis and carcinoma later. Now, cure rate with this drug is close to 100%. And a combination of this drug is resistance is very low. It's a safe drug and almost no side effects. So it's a miracle that has happened within at least my practice time, within my lifetime, from an undiagnosed disease to a diagnosis to scientists winning Nobel Prize and to curing the disease and almost able to eliminate, eradicate, and cure the person completely of a viral disease. So much is the progress that's happened just last 30, 40 years. Next slide, please. Here are the drugs. If you see the first vertical column, the third drug from the top, sofosbuvir. This is the drug. I mentioned there are 7 non-structural proteins. Now, in these structural proteins, each protein needs, and formation, it needs nucleosides. And if we insert a nucleoside analog, which enters and replaces the original nucleoside, it stops the replication. So sofosbuvir inhibits nucleoside 5SB polymerase, which is the key enzyme helping in RNA replication. So it is NS5B polymerase that is inhibited by sofosbuvir. To prevent resistance, it can be mixed with the drugs leadpasvir or velpatasvir, which are also nucleoside inhibitors, they also help in stopping the replication. So combination therapy is close to 100% curable. Side effects are minimal. It's a 90-day treatment, 1 tablet a day, and you get a hepatitis C cure completely forever. Next slide, please. Now, drugs not used anymore. We stopped using these drugs maybe just about 10 years ago or so. The first drugs that came in this armamentarium were PEG interferon alpha. It's interferon alpha, 2 alpha and 2 beta interferons that we used, and ribavirin, which is an antiviral drug. Now, these drugs had serious side effects because we had no other drug, and because we knew how to diagnose hepatitis C. Unfortunately, we're compelled to use these drugs, and the side effects were serious, from hemolytic anemia to anorexia to weight loss, thrombocytopenia, depression, suicidal tendency, murderous tendency, homicidal tendencies in these people. And I've treated many people with this, and I've seen each side effect that's mentioned here. It was a nightmare for both doctor and the patient to treat these people. And they were under constant surveillance. And many times when they became suicidal, homicidal, they just stopped the drugs and prayed that they won't do anything unusual. Ribavirin caused hemolytic anemia, and we continued using ribavirin because there was not the drug, and we stopped giving it when the hemoglobin dropped below 10 or 9. And then a month or two later would restart the whole thing, only to come back to the side effects again. Luckily for us, these drugs are old and ancient and outdated. We have these wonderful drugs now that can cure hepatitis C. So we come so far just in the past 10 years. Next slide, please. Now, to mention a few words about hepatitis A, D, and E. Hepatitis A is quite common in India. This hepatitis A is also called infectious hepatitis. Comes by orophycal route by eating dirty food, dirty water. And hepatitis D is also called delta antigen. It's an RNA virus, very small in size. It doesn't cause any problem by itself, but latches onto hepatitis B and causes hepatic encephalopathy, hepatic coma, and death. People with fulminant hepatitis with hepatitis B have a super infection of hepatitis D, delta agent, along with the B, and that's a killer. This is the cause of hepatic coma in hepatitis B. Then hepatitis E antigen is sporadic. It happens breakouts. There was in Delhi, there was a breakout in 1955. There was a breakout in Kanpur in 1991, and it's still in endemic areas. And once the hygienic conditions are poor, it holds a reservoir in pigs. So in dirty places, these diseases break out. Recently, it hasn't, in India, hasn't been a breakout, but we had to be all the guard all the time. You never know when the outbreak is going to come. And all viruses mutate. So just because there hasn't been a breakout for the past 20, 30 years, doesn't mean there won't be a breakout in future. So we have to be vigilant about these viruses and their mutations. Next slide, please. Next. Now we, as doctors, have to be aware of who's at high risk for hepatitis and who should be screened and who should be a little more aware of that this person could have hepatitis in our clinical practices. This is, I just read it out to you. The newborn infants of pregnant women, household members and sexual partners of chronic hepatitis patients, people living in poor sanitary conditions, and men who have sex with men and multiple partners, past blood transfusion, people who have HIV, people who have chronic hepatitis C can have a B along with it. Healthcare workers are more vulnerable. People who are immunosuppressive therapy can have flare-ups of B and C, which were quiescent in them before. Hemodialysis patient because they get infected during dialysis. The tribal population in India has a 12% prevalence. Jail inmates, for that matter, any institution where there's overcrowding and inmates, they infect each other, and illicit intravenous drug users. So once we have a patient who enters our clinic with any of this kind of a demographic data, we had to be aware this man or woman has to be screened because of the history. Next slide, please. And since we know quite a bit about this hepatitis virus, and we also know the treatment, can this disease be eradicated? Answer is yes. The knowledge about this disease and the virus is enough for us to make a claim that's eradicable disease, just the way we acquired enough knowledge about smallpox and polio, and we were able to eradicate. Similarly, we have enough knowledge to eradicate this disease. And with the concerted effort all over the world, we could eradicate this in 10, 15, 20 years, depending on the governing structure. The 10 steps, and that is behavior modification, education the people, educating people how it happens, improving sanitation, giving good drinking water, hand hygiene is the same story all over, hand hygiene here. And then before transfusion, please screen blood for hepatitis B and C, and screening high-risk people, I mentioned earlier, they should be routinely screened even if there's no suspicion, because hepatitis C is asymptomatic most of the time. And we should vaccinate everyone at birth or close to birth, vaccinate everybody with, and we will not only prevent hepatitis, we'll also eradicate hepatocellular carcinoma, and people who are treatable and curable should be treated. Then, of course, simultaneously, we do need new vaccines and new drugs, which we should do here in India, but unfortunately, in India, we don't have a good research culture. We just copy and cut and paste and copy the West. It's sad, but true. And then we should be vigilant and collect public health data everywhere, so we're aware of if there's an outbreak or endemic area, maybe we can focus more on that. We come to this number 10 point recently in COVID, where they say trace, track, and treat. That should be done for all viruses, all diseases, that you nip in the bud whenever you find through public health data, there's a possibility, attack that center, eradicate the disease from there, and don't let it spread. But that needs an aware population, an aware clinical system, aware doctors, and of course, an aware government that can work in tandem with each other to eradicate this disease. Theoretically, this disease can be eradicated with good effort in 10 to 15 years. Next slide, please. I think I'm done with the lecture and I'm ready for questions. My time is already up. I've exceeded my time by 5-10 minutes. And thank you very much for your for listening to me carefully. And I'm ready to open the questions now. Doctor.
Thank you so much, sir.